today I'm just going to highlight some sort of key points to consider, and I'm actually going to target, interested in everyone's input, but in particular those that are going to be presenting in the next 2 days, that are presenting some of the research findings from projects that have been funded by TVN. I want you to sort of think about some of these things, and when you're presenting, we've purposely put you together with other people that have projects that are similar, so I want you to think about opportunities to actually engage with other researchers that are doing this and actually bring your research forward into a knowledge translation, sort of knowledge implementation strategy, and so these are some things maybe to think about. So just want to say I have no conflicts other than I'm sort of an employee of Alberta Health Services. And I actually wanted to thank Sharon Strauss, because she actually provided a lot of guidance, and a lot of these ideas came from her. And one of the reasons I agreed to do this, because she helped me figure out what to say. So the first off is I want to make it clear that there's a lot of terms out there nowadays, and really they're synonyms. So you might not always hear knowledge translation. Somebody might say knowledge mobilization. They might say, implementation science or evidence uptake, but it's all really different versions of the same thing. So don't get too confused. There's a lot more terms even than these ones I put up. But really we're talking, it's just we like to have lots of, every time we think of something, we want to have a new term for it. So even though we're talking about the same thing. So the first point I wanted to say is that researchers really are not the only ones responsible for closing the research to practice gaps. And I think this sort of speaks to what we just heard about, is engaging patients and other stakeholders. So, really clinicians, and by clinicians I don't just mean physicians, I mean all healthcare providers have a role in trying to figure out how to get research into practice in a responsible way, as well as health administrators, policymakers, educators, and then obviously the patients and public. So everybody plays a role really in doing this. The other thing is clinicians, and broadly clinicians, are not the only target for KT. It's often the first target, but really they may not actually be the most effective group to target. So there's, if you go to the CMAJ, there's just a publication that sort of spoke to the fact that maybe we actually should be targeting more to patients and around self-management, or targeting more to the system overall and looking at team-based changes and case management strategies, so not just at the clinicians and changing clinician behavior. The other thing is knowledge is not the biggest barrier to closing the gap. So in all deference to Denise, education is not enough. It's actually probably not the most important barrier. Knowledge, people do need a baseline knowledge and skill, but that's usually not why evidence isn't getting into practice. There's multiple barriers and across our system. So if you think about the healthcare system, there's lots of financial disincentives to actually do the right thing. Within the healthcare organizations, we often do put the inappropriate skills mixed together, and there was some discussion yesterday about that. The idea of do we have the right people and the right amount of resources in long-term care to actually provide good palliative care within long-term care would be an example. Thinking of the healthcare team, so are the local standards actually aligned with desired practice? So the whole idea of the gaps leading to practice variation, which leads to decreased quality of care. And then our individual healthcare providers, their skills, so not just their knowledge, but their skills, and then their attitudes and beliefs. So attitudes and beliefs can be a huge barrier to taking up new knowledge. And then public and the issue of actually adhering to recommendations, which can be challenging. You might have the intent to change behavior, but to actually change your behavior is hard. And then this is constantly in state of change. So what might have been a barrier a year ago might be different now, because our system is not exactly static. It's constantly evolving and changing, particularly when you live in Alberta. So one thing to think about, if you haven't seen this framework, is a framework that's recently come out of Michi. And if anyone's interested in knowledge translation and the idea of barriers, I would encourage you to read her literature, because she really thinks at barriers in a very practical way. And this is the idea of thinking about potential framework of looking at capability, motivation, and opportunity that actually could lead to behavior change. And so she's broken down capability into physical, so actually your physical skill to make a change, and then there's psychological, so your capability to engage sort of in the necessary processes. Motivation can be broken down to reflective, so that's, when you have time to sit down and think and maybe have a dialogue between clinicians and patients, versus our automatic motivation, which is more emotion-driven impulse, which is probably just as important of a motivation as reflective. And then there's opportunities, both physical, does the physical environment environment actually allow us to change our behavior. And then the social and cultural milieu, and anybody that works in healthcare recognizes that from unit to unit there's a different cultural context, and implementing change really has to think about that. The other thing is the type of intervention to use is not always clear. So we know that there's been lots of different types of interventions studied, and most of them, result in a median absolute improvement around 10%, and that would be generous. Some of them are probably a lot less than that. The other interesting thing that's come out more recently is multiple component interventions may not actually be most effective. They may not be more effective than doing single things. And I think what a better thing to do is to pay attention to which barriers a particular intervention addresses. So if an intervention actually addresses multiple barriers, that's maybe why a single intervention might be more beneficial than a multi-component one where you're not hitting the right barriers. So thinking always about what are my barriers and how do I link my interventions to my barriers. And then this is a good database, the Treatment for Change database, which actually goes through a lot of the evidence around different strategies to actually implement. So it's openly available. The other thing is to consider using theory-based implementation strategies. So there's some evidence that if you actually use a theory and approach, a standardized approach to your implementation strategy, you're more likely to have an effective result. And there's lots of theories out there and more publications coming out about reviews of these theories and where to apply them. And I wanted to actually just introduce you to one thing sort of taking the COMBI framework further, and that's the mapping interventions to barriers using the behavior change wheel. And this is work of Michi as well. It's a synthesis of 19 frameworks to classify interventions. You can see the COMBI ring is in the middle. The red ring is 9 intervention elements, and then the outer ring is linking it further to policy, and there's 7 policy categories. And I'm just going to highlight some of the ones that I think are most relevant to this group and what we do as far as the interventions. So education obviously is still there, and increasing knowledge and understanding isn't important. It's not something to forget about, but we can't stop there. We can think about restrictions, so rules around sort of making it hard to do the wrong thing. Education, restrictions. And then there's environmental restructuring. So that's actually making changes to our physical and our social context to how we implement things. There's modeling, so providing an example of that people to aspire to, which is, I think, can be a key strategy for a lot of people in this room. We obviously have an interest in this area, and so it's changing attitudes and behaviors of our colleagues and the trainees that work with us. Enablement, so actually increasing the means and reducing the barriers to giving you the capability or opportunity to change. And then training, which involves more about skills. And there's 3 others that I think are less relevant around coercion, incentivization, and persuasion. But there are other interventions to think about. And then this gives just a brief example of mapping. So, if you knew what your barriers were, you could map out your interventions. For example, if it was physical capability, you might think about training and enablement. If it was around automatic motivation, so the impulsive things we do, you might change environment, you'd use modeling might be effective, and enablement might be effective. So as I said, thinking about the intervention you're choosing, which barriers does it address? And then an important thing is to think about sustainability, and this is probably the hardest part, I think, of KT is the sustainability. So it should really be considered right from the start as you plan your KT plan. And it includes the post-implementation surveillance of the intervention and outcomes and the impact on the healthcare system. And it may require that you actually have to change your intervention and that you may have to reassess your barriers and facilitators, because often when we get into these projects, we realize as we go that we missed barriers or we misunderstood barriers. And it does require ongoing engagement with the stakeholders, which is what's important with KT, is that all stakeholders are at the table and they're engaged and they take ownership of what you're doing, because they're more likely to continue that change and actually put it into the standard of care on a routine basis. Things to think about. So project funding, unfortunately, doesn't factor this in. So we very short-term project funding, and then our resources are gone. So how do you actually sustain something when the resources are gone? The other thing is policy and healthcare organizational cycles differ from research cycles. So a fiscal year for policy and healthcare is different than the funding cycle of CIHR, for example. And then often we have competing priorities. And I know that's a huge issue. I know within Alberta Health Services is constantly new agendas and things conflicting, and we're trying to get better at making sure what we do is more consistent for frontline healthcare workers, because we have an issue with change fatigue in many healthcare settings, so it's something to think about. The other thing, which I think is really important for particularly our network, is around capability building in KT. And we need to think about the researchers and the researchers that are supported, do they have the capability to actually implement and disseminate their findings appropriately? Do our healthcare organizations have the ability to do this? And in Alberta, one of the ways is through our strategic clinical networks is how we're trying to accomplish this within our healthcare organization. And then policymakers as well. And there's some interesting work that's going on around targeting KT to policymakers that's actually going on around here in Toronto, being led by Sharon Strauss. And then if you're interested, there's lots of resources in KT Canada. So KT Canada started as a national team around KT researchers. It was initially funded by CHR and CFI. And the funding from CHR and CFI is now coming to completion, but we still have a strong network, and we have training programs, and I think there's several people in the room that are probably involved in this network and or have been trained by this program. So there's some very great resources, and they have ongoing ways to engage, and we could definitely TVN could be taking advantage of this as a resource. And then the last thing I wanted to talk about is this, the KT imperative. So the idea that not everything needs to sort of be disseminated to everyone. You need to be responsible as a researcher about where does your research actually realistically sit in context to other research? Is it new and novel and really should be targeted towards other researchers to sort of prove the concept that you've developed? Or are you to the stage where it's actually ready for implementation? So you need to know where your research sits, and you need to do appropriate KT strategy. So you don't need to necessarily do extraordinary efforts to disseminate and implement broadly, depending on where you're at. So the idea of common sense to think about. Take academic rigor to actually how you implement your KT activities.